Okay, hello, good morning, welcome everyone, or it could be afternoon or early morning for Shunya in this case. But my name is Austin. I'm sort of been a part of the VMR community for a little while, and I'm here today to discuss a case with my brother Alec, and then Shunya, who's all the way from Japan and woke up at 2 a.m. to bring this case to us. So I'm sure it's going to be spicy, and he's going to really challenge us. And thanks so much to him. So I'll kind of pass the mic to Alec, and we can go from there.
Yes, thank you again, everyone, for coming. Austin and I have been off and on involved with the CP solvers for a while, and we're really excited to get to learn from you all and to try our hand at a case. It's been a while since we've discussed together, so we're going to have to brush off the dust. But thanks again to everybody, and especially to Shunya that woke up so early to present us a case. So this is, if you have comments to make or thoughts to share, please be active in the chat, or if you want to speak up, we would love that. And please just call us Alec and Austin. Okay, let's go.
Right, so today's case is kind of like ER case. I have 5 articles for today's case. And this is a patient I saw a couple of weeks before during the overnight shift. So I'm really excited to jump in with you guys. So article number 1, this is a 66-year-old female with a past medical history of diabetes, type is unknown, and hypertension, who was brought to the ER presenting with abdominal pain over the past 4 days. And that's all for article number 1.
Okay, Austin jinxed me and told me to go first, so we'll give this a shot. Thank you, Shunya.
Yep.
So, I think so far we have the age, we have a little bit of the background here, and then we have our chief complaint, which is abdominal pain. And 4 days, not hyperacute, but I'm going to call it acute at this point. And it will be interesting to layer in other associated symptoms and how the past medical history may relay into this, and whether this was a little bit more, started with something mild and then progressed to something severe, or something that just started and hasn't gone away. And, it's a little hard to, but diabetes and hypertension are so common, it's hard to know how much of that is going to be helpful in our final diagnosis or not. The diabetes, could the patient have DKA associated and have abdominal pain associated with that? Hypertension, always have to think about vascular-related causes, specifically dissection, or those are both significant risk factors for ischemic heart disease. So whether or not this abdominal pain could be in more atypical presentation for ACS. And then, how well controlled is the diabetes? Is there a risk for infection here? Or could these things just be entirely unrelated? So, it's a little hard to make a lot of progress here. I would say for abdominal pain in particular, I'd like to sort of work my way out and then go in. So is there something on the skin? Is something in the abdomen? Is this for nerve related? Is it organ related? Is it in the retroperitoneum? Or is this referred pain from, down in the pelvis or in the chest as well? So, I think a lot of thoughts here. So I think especially with an ER complaint, we're going to want to know how sick the patient is and how they're doing. What are the vital signs? What other company is this keeping? And, kind of make an assessment for there, what sort of rapid fire things we might need to do, and whether or not this patient will have imaging in their future. But I guess those are my initial thoughts. So Austin, what do you have to add to that?
No, I mean, that was incredible. I really don't have anything to add. The only thing I'll say is that as a sort of a problem-solving exercise, I would be remiss if I didn't mention hypercalcemia to start, because every single time I do one of these exercises, the answer is always hypercalcemia for abdominal pain. So at least I can say I didn't miss it this time around. But that was an incredible discussion. I really don't have anything to add. So Shunya, back to you.
All right, so let's go to the article number 2. I think we have a great initial start. So 4 days prior to the presentation, the patient started having abdominal dull pain, primarily located on the left upper quadrant area, which moved to the epigastric area, and the intensity being rated 4 out of 10 initially, which had been worsened to 8 to 9 out of 10, despite her over-the-counter medication use. And she could not tolerate the pain at all and could not sleep at all, which prompted her to call an ambulance. And she noticed she had never experienced the symptoms like this before, and she now reports that the pain is exacerbated by breathing. And review system-wise, the patient denied vomiting and diarrhea, and the rest of the review system is pretty much unremarkable. And her nutrition-wise, she has a decreased PO intake since the onset of abdominal pain 4 days prior, and the last meal was a bit of noodles, no problem in intaking water. She also endorsed having a black-colored stool couple of days prior, denied having eaten any black-colored foods. And past medical history, she was previously diagnosed with diabetes, its type is unknown, and hypertension, for which she is taking valsartan and stagliptin, respectively, and no problem in medication adherence. She's also taking an annual health check, which reported no abnormalities. That's all for article number 2.
Okay, awesome. Yeah, so we have some more sort of history to sort of layer in and help us narrow our differential diagnosis. I guess my thoughts here. There's many different approaches to abdominal pain, and Alec gave us a little bit of a flavor that I think at least I heard from Reza first, which is kind of shooting an arrow and going through and seeing what structures you hit, and that can be very, very helpful. In her particular case, we're sort of in the left upper quadrant epigastrum area. And so if we think about the structures that live in there, colon can live up there, spleen can live up there, the stomach, into the rectum peritoneum, the pancreas. But I think if we take a step back and layer in what I'm translating with as pleuritic chest pain, then certainly all those structures are can still be invoked. But now we have to kind of think about our neighbors, as Alec had mentioned before. Like, could there be like a left lower lobe pneumonia, or could there be some other, I guess, intrathoracic pathology that could be at play. But there's really we're getting a signal for pain in the abdomen, but we're not really getting much signal for anything else to help us. So usually, if people have belly pain, they might have vomiting, they might have diarrhea, they might have fever, they might have other things to sort of help guide us. The only thing that we really got was that there's these dark stools that she had, and Shunya gave us a nice clue that there wasn't any dark foods or anything in particular that could be leading us to kind of go down this false path. So if I translate melena, epigastric pain in an older woman with vascular risk factors, I'm thinking of a bleed of some kind, and common things being common, I'm thinking of peptic ulcer disease, in particular H. pylori. And then, if we go a little bit further and say, hey, this woman's had annual health checks, how protective is that as far as detecting a cancer or something like that? Probably it's helpful. I don't live in Asia. I don't have a lot of experience with countries like Japan that do sort of routine screening for gastric cancer. And so I'm not sure if that's been a part of her regular maintenance or not. So that would be an interesting question to ask. But, sort of a no miss or, concerning diagnosis I'd be thinking about at this point would be gastric cancer. So I've sort of rambled on for a while, and I'll pass it on to Alec. But I think my main, center of gravity right now is there's something, in the stomach. There might be a bleed, but I think we still have to be open to the possibility that this could be above the diaphragm or could be below the left upper quadrant and epigastrum as well. So Alec, what else do you have to add?
No, that was awesome, Austin. And I love that you sort of layered in your knowledge about how screening for different types of cancers can change depending on your geographic area. So here in the US, we don't typically screen for gastric cancer, but I know in Asia that they do, and maybe Shunya will share that with us later on. But yeah, the pleuritic component of the pain is interesting. Is this just sort of upper abdominal inflammation, something going on in the spleen, and every time she takes a deep breath, that's why she's having irritation? Or like you said, left lower lobe pneumonia, could she have had a PE and an infarct and has some pain related to that? And it does radiate to the epigastrum. So, is this just referred pain? And it could be something more pancreatic. It could be something related to other things in that area, in the colon and whatnot. And, in addition to peptic ulcer disease, whether or not there could be any ischemia involved, we don't know how significant, how poorly controlled and for how long she's had diabetes and hypertension, or her other health history habits, if she's been a smoker or, has a significant family history of vascular disease. It'd be interesting to know if there's a prandial component to the pain. Certainly the melena is suggestive of something intraluminal, as long as the melena isn't, we haven't, I guess, confirmed it's melena, but that's what we're translating the dark stool into. So, it doesn't sound like this is upper airway blood, is it she's not bleeding from her mouth or in her nose, and then it's coming out looking like melena when it may not be. She's not taking Pepto-Bismol or iron, although it would be helpful to know, did the stool start after she was taking these over-the-counter meds, and which over-the-counter meds was she taking? Was she taking a lot of NSAIDs? Was she taking a lot of Pepto-Bismol? Could she have just had run-of-the-mill GERD and then decided to take a lot of NSAIDs and then now has a peptic ulcer or something like that? So I think the time course of the medications and what exactly she was taking will be helpful. And then whether or not we get any sort of sense of inflammation based off the vital signs or some of the labs, and because I think that will help expand our differential diagnosis. And then, I think the DPP-4 inhibitors or the GLP-1s are associated with increased risk of like hepatobiliary disease. But I don't, sounds like her pain is mostly on the left, but you wouldn't want to miss something on the right side as well. So, I think going forward, as far as what I would like to do next, definitely want to see how the patient looks, what the vital signs are. And then if there's anything concerning on exam that might suggest perforation or an acute abdomen, but I imagine this patient has some sort of abdominal imaging in her future. And then, if this melena turns out to be corroborated by anemia or something else on physical exam, potentially an endoscopy, but I'm really interested to see what comes of that. So Shunya, what do you have next for us?
Right. So just I want to answer the couple of questions you guys had. Thank you for asking the questions. So medication wise, I said she had taken the over-counter medication, and which is just a painkiller, over-the-counter painkiller, and which took a couple of times. So there's no overdose or something like that. And for her annual health check, I don't have any further information about that, but she didn't mention any cancer presence or something like that. And also, Mario asked me the type of abdominal pain. It was more of a common go type of pain rather than the constant severe pain. So she had been treating the pain for like 4 days until she came to the ER. She was actually brought to the ER by the ambulance, so which is kind of like severe. So that's all for the history part of it. And then let's go to the article number 3, which is the history, physical examination. So her vitals, respiratory rate 18, heart rate 90, and the blood pressure was as high as 96 and as low as 63. Temperature 36.3 degrees Celsius and saturating 99% of room air. And general appearance wise, she was anxious appearing, not in this respiratory distress. And the cardiovascular pulmonary exam was pretty much normal without any significant findings. And let's jump over to the abdominal exam, which revealed tenderness to palpation present over the upper abdomen, guarding as well over the same area without board-like rigidity. And also we did digital rectal exam, DRE, in which we obtained a black card stool that tested positive for fecal occult blood. Indicating the presence of melena. And neuro part, which is pretty much normal. And that's all for article number 3 of physical examination.
Okay, wow. Shunya has given us some additional information here. So just looking at the vitals, the blood pressure is the first thing that stands out for me, especially in a patient with diagnosed hypertension that is on medications. So certainly very concerning for volume depletion, but in corroboration with the melena that we have now confirmed on exam, definitely concerning for an active bleed. She's not significantly tachycardic, but I also don't know what her baseline heart rate is. For her, this could be tachycardic. But the pressure, and especially it seems like the 96 was on the higher end, so that would be incredibly concerning. Her exam, we don't really get any sort of signal until we get to the abdomen, where it seems like she had some guarding as well, but I don't think Shunya said that she had rebound. But certainly that in combination is very concerning and would warrant more expedited imaging, probably through the CT scanner. And then if that didn't show anything suggestive of perforation, definitely calling our colleagues to do an endoscopy to try and figure out where she's bleeding from. But all of this would happen after we stabilize the patient. We resuscitate the patient, have to be sure that the blood pressure and the other vital signs are stable. And, I don't want to anchor too much on the, melon of abdominal pain and go straight to the GI tract, although that is by base rate going to be the most common. But also need to think of, any sort of ischemia that may cause the gut or specifically the stomach to become ischemic and increase your risk of bleeding and could cause hypotension and other things. Maybe if she had a dissection, but with the pressure is probably less likely. So, I think overall, when I see this, obviously I'm very concerned about this patient. Gonna need to stabilize, get her some blood, likely, depending on where things are shaping out, at least resuscitate her with fluids. And then once stabilized, look towards imaging, see if the labs show anything, and just go from there. And then, it doesn't seem like she's altered. We're not getting a sense of shock quite yet, but we're gonna have to keep a very close eye on that as well. And then, if it seems like the bleeding is not quite as significant as we were thinking, whether or not adrenal insufficiency could be at play with some sort of non-descriptive abdominal pain, although the abdominal pain seems out of severity than what I would expect for somebody with just adrenal insufficiency. So, I think I'm very worried about her upper GI tract in particular, and then it'll be figuring out what exactly is causing her to bleed there. Sorry, I think I've just been rambling quite a bit, but Austin, save me here.
No rambling. I think you really covered everything really nicely and sort of discussing the, in particular, we're kind of in our management mode before diagnosis mode at this point. We need to make sure that she has the appropriate IV access, that we're getting a type in screen. I think, Shrina's helping us out. I think that in the sense that she's had regular screening and annual exams. So, we always translate upper GI bleed, usually to peptic ulcer disease, but especially in the United States, or really globally, where obesity has become, an epidemic, and I've certainly in my clinic diagnosed a lot of people with sort of cryptogenic or unrecognized cirrhosis, and so we always need to, at this day and age, really entertain the possibility that this could be a variceal bleed, and that we need to manage it as such. For her, we're really not getting any signal of that. I didn't see any comments in particular about any stigmata of chronic liver disease. We don't know the BMI or anything like that. But, I always think about that nowadays, just because I've diagnosed so many patients with cirrhosis that, really had no idea that they had cirrhosis, or we just said they have elevated liver enzymes, and we just watched that for years and years in the clinic. And, unfortunately, that eventually leads to cirrhosis. But, as far as the differential diagnosis, I agree. I think we're at this point sort of narrowing on the GI tract, in particular the upper GI tract, and we're seeing, translating evidence here that there's an upper GI bleed, and sort of going down that pathway will be helpful with kind of all the diagnostic tests that you mentioned. But lastly, I just wanted to compliment Shunya on just an amazing presentation thus far. It's been incredibly well organized, and just I can't believe it's the first time that you're doing this. This is excellent. So thank you so much.
Yeah, thank you. So let's dive into the article number 4, which contains a couple of quick workup I did before presenting the case to my attending physician. And before that, I just want to mention one thing which Maria asked me. Thank you for asking, which is any weight loss history? The answer is no. She denied any weight loss recently. I think which is the key part of history. I should have mentioned it. So thank you for asking that. So broad test wise, CBC normal limit within normal limits without any significant changes, and BMP CAM7, BUN of 30.1, creatinine of 1.28, bicarbonate of 47.6, glucose of 289, chloride of 93, potassium of 4, sodium of 130, calcium of 9.5. In addition, her CLP was 5.46, and her coagulation panel was pretty much normal. And I ordered ECG, just I won't rule out any presence of acute coronary syndrome, something like that. And ECG turned out normal. And we also ordered a abdominal X-ray scan, which also turned out normal. So that's all for article number 1.
Okay, wow. Thank you so much. And just to be certain, did you say that the bicarbonate was 47?
No, bicarbonate. Yeah, CO2 of 47.6.
47.6. Okay. All right. So I may try to embarrass myself by doing some math. here, but I think if I'm doing the math correctly, there shouldn't be any anion gap here. Maybe someone in the chat can provide me some relief with that. So, I think here, if we take a step back and we say, okay, the first all, the CBC was normal. If we ask ourselves, should we be reassured by that right now? And I would say no, in this particular case, just because the relatively acute nature of her symptoms and the presence of melanoma on exam. So, even though the CBC is normal, the symptoms, she says, have been going on for 4 days. As Alec mentioned at the beginning, there could be sort of an acute on or hyperacute on acute process going on. So I don't know how reassured to feel about the normal CBC at this time, though. I might take a step back and just breathe at least a little bit in the moment, that we don't need to be preparing blood at least right in this exact moment. Moving on to the chemistry panel. We see the sodium of 130, which is relatively mild, and with a glucose of 289. I'm probably not going to invest too much time going into the hyponatremia, though. As internists, we do love that, but I'll kind of save that for another time. But really stood out to me was, the CO2, and then the BUN and creatinine. So, I don't know what her baseline creatinine is, but given that Shunya said that she's been having regular care and she's 66 years old, I would be surprised if 1.28 would be her baseline. So this is likely above her baseline. And a BUN of 30, kind of a ratio in the 20 to 30 area, but does potentially seem consistent with an upper GI bleed, or this could be volume depletion. As far as how to translate the CO2, I guess I'm struggling a little bit with that. And then Shunya, do you happen to have the units on the CO2, just to make sure I'm interpreting it correctly?
Yeah, actually that was PCO2.
Oh, PCO2. Okay,
Yeah, so
all
it's
right.
not by cover, so I'm so sorry for
All
that.
right. No,
Just
that's
my
my mistake. Okay, no, that's my mistake. So thank you for clarifying that. So I won't go down that way right now. Thanks for Shunya for saving me. So yeah, I would say then stepping back, the BMP, really taking away just the kind of elevated BUN and creatinine and the ratio in particular. The CRP, I think, given her exam, her presentation, I'm not surprised that there's evidence of inflammation here. So I'm not sure how much diagnostic progress we could make with this right now. The coagulation cascade, at least initial testing was normal and reassuring, and that's really most important from a management standpoint. And so we don't need to be thinking about reversing anticoagulants or giving product. And the EKG being normal, I think that was an excellent test to pursue, and we don't see anything there. And then the abdominal X-ray, I'm not certain how much it can really help us in this scenario. I think, given that we're invoking that this is an upper GI bleed, unless there's perforation, or I don't, and then we see free air. I'm not certain exactly how it helps us enough diagnostically, how it shifts our probability that there may or may not be a visceral issue going on, to not pursue a CT scan or other advanced diagnostic imaging. So those are my thoughts right now. I mean, I feel like all roads lead to a tube of some kind, and whether that's a CT scan tube or a tube that we are going to intubate into the esophagus. I think that's where I'm at right now. So Alec, what else do you have to say?
No, I love the tube of truth reference. I guess, just to, add to that, I think in these situations for this patient with the location of the pain, I'd be interested to know what the lipase was. Would also be interested to have some liver chemistry tests as well, just to be sure I'm not sort of anchoring myself, but knowing that with melena and elevated to BUN to creatinine ratio, certainly quite suggestive of an upper GI bleed. And I think as well, it would be helpful to know how the abdominal X-ray was performed. Just like Austin said, he was worried about the possibility of a perforated viscus, whether abdominal X-ray was upright or when the patient was laying down. You're only going to actually see free air when the patient is upright. Otherwise, if they're laying down, it's just going to sort of not be gravity. It'll be gravity dependent, but not in the way you want it to be. It will be just sort of spread out instead of up. Yeah, and then, I'm glad that we didn't have to go down a negative anion gap and a very high serum bicarbonate. So, I think the BUN to creatinine ratio is probably just reflective of the bleed, but also of hemodynamic instability as well with the significant hypotension. There's a great tutorial from Tony Brew about the BUN to creatinine ratio and why it's elevated, typically more from intravascular volume depletion than the blood volume. It's the blood being broken down itself. Although there was a recent Curious Clinicians episode where they went into depth about, how depending on the volume of blood that may actually be contributing. So if you haven't heard either of those, highly recommend them. But yeah, I think at this point, depending on how her abdominal exam is changing, or how she's doing clinically, and as long as she's stable, depending on your institution, whether or not you have regular access to GI or whatnot. I think ideally I would just go straight to an endoscopy, but depending on your practice setting, the CT scan may be the thing that you go to first. But certainly would be calling my GI colleagues to go take a look to see why this patient is bleeding in the upper GI tract. And
yeah. Thank you. So in terms of her baseline creatinine level, we could not reach any of her previous medical records because that was the first time she came to our hospital. And so let's dive into the record number 5. This is the final record. Subsequently, I presented the case to the attending in the GI service, who told me to send her to abdominal pelvis CT scan concerning the any presence of perforation, because it worsens the perforation if we do the endoscopy before CT scan. So we ordered CT scan before endoscopy. And I also did some IV drop concerning her relatively low blood pressure, especially because she has a past medical history of hypertension. So I can show you the exact image of CT scan because it just hit the violate the HIPAA-related flows. So I just say the explanation for that. So abdominal to pelvis CT scan without IV contrast, the presence of free air just below her diaphragm was reported. And I consulted the patient to GI surgery instead of GI medicine, and she's now being taken care of by the service. And prognosis-wise, I have heard the patient did not undergo surgery, mainly because the perforation size is relatively small, and therefore she's now receiving supportive care and showing signs of improvement at this point. And for this case, the etiology behind her GI perforation is essentially still not unclear. That's all for today's case. So thank you for listening.
Well, awesome case. Thank you so much, Shunya. Thank you for taking such excellent care of this patient and just giving a masterful presentation. I agree with Austin. I can't believe it's your first one. And hopefully this is the first of many. So yeah, I think just doing a quick cognitive autopsy here, I think just knowing test characteristics can be very important. I think we were all sort of eyeing in on the GI tract, but I think the X-ray, even though it's normal, is not necessarily going to be perfect depending on how you take it. And then, I think sometimes over the paper script, it's really hard to get a sense about how concerning somebody's exam is for a perforation. But I think Shunya really demonstrated that well, that we probably should have been pretty concerned about that. And a lot of times you don't have to get imaging for somebody that has a GI bleed if their exam is otherwise reassuring. But I think in this case, retrospectively, really recognizing some of the limitations of the X-ray, but also like the severity of her abdominal pain, which I don't always see in people that have, like a GI bleed, I think is very helpful. And I guess my gut would tell me that she probably had a peptic ulcer that just perfed. And that's why that was the initial cause of it. But I guess we will never know because they probably don't want to do an endoscopy for some time. Yeah, I don't know, Austin, what do you think?
No, it's such an excellent case. And, I think to your point, I didn't really do a good job of teaching that. If I think about the patients I've taken care of with GI bleeds, so many of them really don't have a predominant feature of pain, right? It's really like, oh, I have blood in my stool, or I have, bloody stools, or we're thinking more about lower GI bleeds, but pain being predominant. And, I've been out of the hospital for a little while, so maybe Alec can, if this is, against what you've seen in your practice. But if I think back, really most of the time, there might be some discomfort, but the exam is not, concerning like this exam was. And so really, I think it was that feature that led us down like, hey, I think this person needs, more advanced imaging as opposed to, hey, I just want to follow the blood in and of itself. So I think that was something I should have done a better job of really stepping back and saying, hey, this is the reason that I'm doing this. And then to your point, Alec, I think the test characteristics are really, really key. I think we think about certain tests as definitive or not, but realistically speaking, every single test that we do is on a spectrum. That includes our history, that includes our physical exam, that includes the labs, that includes imaging, endoscopy, biopsies. Every single thing that we do in medicine exists on a spectrum. There is nothing that is absolute. And I think, this particular case, the abdominal X-ray was the example of, if we had stopped there and said, hey, this woman has pain, and gone through the endoscopy, then, potentially this woman could have had, a really poor outcome. But Shunya did such a great job, got the patient exactly what she needed. And, now she's recovering, which is great. So, I guess we can move on. I guess, Shunya, any other reflections from you about this case and things that
Uh,
you really took away from it?
Yeah, a couple of running points I had from my perspective was, I reported in the history part, her pain was exacerbated by breathing. And is there any association with the free air just below the diaphragm that is causing the periodic chest pain like presentation in this case? I don't know exact mechanism for it, but I think there's some association between the two. And also, like when it comes to the BUN to creatinine ratio, that was a returning pivotal point for me when I was seeing the patient. When the blood test came back, oh, this is like the sign of GI bleeding, and then went to the GI service immediately. So having the ratio above the like 20 or something, we have to think about the decreased perfusion in the kidneys, and also like congestive heart failure, dehydration, or like GI bleeding, like in this case. And also, I intentionally did not include bowel sound findings in the physical examination part, which is, I think Dr. Ravi mentioned the same thing a couple of days before in the VMR session. But actually, the bowel auscultation is generally reported to have low sensitivity and positive predictive values, even for healthy patients. This is some exception for, I think that was ileus or something. But basically, we have low sensitivity for diagnostic skills, diagnostic tests from bowel auscultation. And also, like the location of the sound does not localize the underlying pathology behind the abdominal wall, because it travels, up and downs, and right to the left from the abdominal wall. So I think it's important point to exclude the bowel sound, findings in this physical examination. Or I did not do that for the patient. You can see the more details in the core IM podcast. That was, I think, in 2022 or something. So that's it for me. And let's move on to the teaching point.
Thank you, Dr. Alec and Dr. Austin, for this amazing discussion. And thank you, Shania. This is an amazing case, and I learned so much. And here are some of the teaching points. So this patient, we start off with the chief complaint and abdominal pain. And we have to ask the question about the timeline of the presentation. Is this an acute, subacute, or chronic case? If this is a first-time presentation, is a recurring presentation, what is the characteristic of the pain? Also in this patient with the past medical history of diabetes and hypertension, this patient had the risk for ischemic disease. So we have to think about aorta dissection or AAA, if there's any infection, if there's what organ or related to this presentation, is it nerve related, if there are any other associated symptoms, or if there is a cause for electrolyte disturbances such as hypercalcemia. And also we talk about the anatomical location, because the patient was presented with a left upper quadrant pain that is moving to the epigastric. We think about the spleen, stomach, left kidney, and pancreas. Also, it's important to screen for cancer according to the geographic location. In this case, this patient, we mentioned about the gastric cancer, which is a prevalence in Japan. So this patient also had the associated symptom beside the abdominal pain, had the melena, which is, we had to ask if this do the presentation started after the medication use or not. And one of the most common cause for melena is the peptic ulcer disease. And when we went to the vitals, there was something that is worrisome, which is a low blood pressure, and especially in a patient with a past medical history of hypertension. So this patient with hypertension and melena, it is important that we need to start with resuscitation with fluid. And stabilizing the patient in this particular case is an urgent matter. And then we started to anchor about the different differential diagnosis, especially for the upper GI tract bleed, which is esophageal varices, pectic ulcer disease, AVM, Mahler-Weiss syndrome, or even cancer. And Dr. Alec mentioned about the abdominal X-ray, which is very important to for the diagnosis to know exactly how it was performed. If it's upright or decubitus, which is in only the upright position, it's going to reveal the free air due to viscous perforation. And even though if the abdominal X-ray come back normal, we still need to perform other more specific diagnostic tests as a CT scan, which in this case give us the diagnosis, which is GI perforation. So thank you so much, and these are my teaching points.
Awesome job, Hui, for sharing all of that. I apologize. There's people working on my house in the background if it's loud. Yeah, just an amazing case. I think Shunya just had a very thoughtful comment about like just focusing on the reasoning and not getting lost in the zebra diagnoses, but more of things that we see every day. And I just couldn't agree more. Like it's super fun to talk about the rare stuff, but in the everyday things that we see and do, you know, you want to be able to help the most patients you can in front of you, and learning some of the esoteria can be important at times, but having a foundation that will get you to the answer, even if you don't know it off the top of your head, is so much more important. And I think that's part of the mission of the CP solvers and stuff that you guys and, you know, Robbie and Reza and everybody on the team just continue to hone in on. And that's why Austin and I love this stuff just as much as you do. So thanks for just a great case and for sharing and all the activity in the chat. And thanks for having us. It was really fun.
Bye-bye.